Hey there, welcome to the show. Did you know that there are 1 billion women in menopause? Most of them know little or nothing about hormone replacement therapy. And what they do know either confuses or terrifies them. What if somebody, let's say a trained, experienced healthcare professional, could explain hormones for menopause in a way that anyone could understand? Steve Goldring has been a licensed pharmacist in Utah and Colorado for over 30 years. Also known as the hormone pharmacist, Steve has spent most of his career talking with women about hormones over the pharmacy counter. Over the past decade or so, he started creating courses that empower women and their husbands with the clarity and confidence to make informed HRT decisions. Steve has earned multiple certifications in hormone replacement therapy. He's worked with hundreds of physicians, nurse practitioners, and PAs all over the US, Canada, and even in the UK. Many of those hormone providers subscribe to his Simple Hormones patient education program that helps streamline their medical practices. So, without further ado, I would love to introduce you to my first podcast guest, Steve Goldring.
Great.
Welcome, Steve.
Thanks for having me, Claudia. It is going to be fun to talk about hormones and menopause, my favorite topic.
Mine too. So, before we get started, if 1 billion women are in menopause, then 1 billion of them would have gone through perimenopause at some point, correct?
I think that's probably true. It makes sense.
Yeah. And obviously, the name of this show here is Perimenopause Simplified because, in my opinion, it is a really important time in a woman's life to get educated, be prepared, and advocate fiercely for themselves. Quite frankly, as if their life depends on it, because it does. So, I want to just get into all of it. We have a bunch of questions here for Steve. So, again, thank you for being here.
Thank you so much for having me.
Yeah. All right. So, why don't you give us a little more background on how your experience as a compounding pharmacist led you to shift your focus to educating patients and providers in regards to hormones and hormone replacement therapy?
Right. So I was the the lead pharmacist at a pretty large nationwide compounding pharmacy for maybe 10, 12 years. I oversaw a bunch of pharmacy technicians. Our pharmacy, by the way, was inspected by the FDA the worst week of my life. But our pharmacy came through with flying colors. We did not get any type of warning letter or reprimand or anything from the FDA. They said, "You're doing a great job," which it wasn't me, it was my whole team. But that was a real sense of relief. But that was also the beginning of the end for me as being a compounding pharmacist. We'll talk about this a little bit later. The regulations were a big deal, and we'll probably cover that in a little bit later question. But I'll back up a little bit. As you mentioned early on, I've been talking with men and women over the pharmacy counter for many years, decades even, especially talking to them, giving them counsel about their hormone prescriptions. The vast majority are women in perimenopause and women in menopause that I talk to about estradiol, about progesterone, and other hormones that they were receiving. Many of them were worried, or they had questions or concerns or hesitations. And so I found myself over the years, I would talk to a woman in, let's say, in menopause or perimenopause at the pharmacy counter. The conversation's supposed to last 5 minutes, right? I'm telling her what to do with her prescriptions, and she has questions and she asks those questions, and I'm excited to answer her questions. But that 5 minute conversation kind of stretches out and becomes 10 minutes and 15 minutes and 20 minutes.
Mm-hmm.
And it's great. I'm enjoying it. And she's really gaining a lot of wisdom and a lot of knowledge. And really, she's starting to like relax and understand that these hormones are going to really make a difference in her life. But the only difficulty is there's another woman standing in line behind her who's waiting to ask the very same questions that that woman just asked. And then there's a third woman standing behind her. And like every day, I'm seeing a dozen, 2 dozen women or more asking the same questions. And so I started to think about maybe there's a way that I can answer a lot of those questions instead of on a one-to-one basis. Maybe I can answer them one-to-many. And maybe I could I started to use the idea of video and video courses that can really kind of boil down the things that women ask about the most commonly asked questions and the things that women need to know about hormone replacement therapy. And so I've created a number of courses that I offer directly to patients, but I also offer them through physicians and nurse practitioners and PAs to help them teach their patients. And so that's what I've emphasized over the last decade or so. And as I mentioned, I've totally gotten away from working at the pharmacy counter. And now my passion is really all about helping, especially women in menopause and perimenopause, understand the truth about hormone replacement therapy. And we'll talk about the fact that we haven't always gotten the truth about those things.
Oh yeah. Oh yeah.
So that's kind of the basics, the short story of how I ended up becoming the hormone pharmacist. A lot of other people might be involved with hormones as pharmacists, and they can call themselves the hormone pharmacist, but I have the domain hormonepharmacist.com, so I guess
You're the OG, as they say.
right.
Thank you. No, that's awesome. And I took your course, Simple Hormones, and it was awesome. It's very quick to get through. It's just, I love how you include the science because everyone wants to see studies and all that. And it's just really well done. So we'll talk about that later, how you can get your hands on that. But definitely check that out because Steve is just a wealth of knowledge. All right. So moving along, there's a lot of confusion, let's say, around the difference between the FDA approved or commercial available hormones versus compounded hormones. So can you give us a general overview of the difference of these?
Yeah, so there are commercially available or also, as you mentioned, FDA approved hormone replacement therapy products. So examples might be there's a brand name capsule called Prometrium, which contains micronized progesterone. It's an oral capsule, and that's available commercially from a lot of pharmacies. There also is a generic form, both of which are officially approved by the FDA, the Food and Drug Administration. There are estradiol tablets and patches and gels and various forms of estradiol that are commercially approved. They're manufactured by a drug manufacturer. Now, in contrast to that, there are also compounding pharmacies that will make, they're basically making compounded prescriptions that are specifically for individual patients. We can get into some weeds about that, but in general, a compounded prescription is kind of customized for that individual patient. So here's an example. Progesterone capsules come in, I think, a 100 milligram and maybe a 200 milligram commercially available. They are in an oil-filled capsule. If you cut them in half, the oil goes everywhere and it's all over your hands, it's all over your counter. There is no way to cut that capsule in half. So you are either going to take 100 milligrams or 200 milligrams. That's it. Or you could take 400, I guess.
Right.
You could,
If you double it.
but there's no flexibility at all in the dosage form of just this example, progesterone capsules. Now, on the other hand, if you were to get a progesterone capsule from a compounding pharmacy, I have one of my videos is about progesterone intolerance. Certain women, a small percentage, maybe around 10 to 15%, have a problem with progesterone and it causes some severe reactions. And those women often are started on a very low dose of progesterone, like maybe 5 milligrams or 10 milligrams.
Oh, wow. That low. Okay.
Just cannot get that dose from commercially available progesterone. That is a dose that has to be compounded by a compounding pharmacy. So you can get almost an infinite number of doses from a compounding pharmacy. You could get a 1.2 milligram progesterone, or you could get a 400 milligram progesterone, or any dose in between. There are lots of different ingredients that maybe a person might be allergic to or have some type of reaction to. Those could be removed from a compounded prescription. So they're both contain an FDA-approved drug or hormone called progesterone. The FDA has said this progesterone is approved within the context of these manufactured drugs. Because it is part of a FDA manufactured drug, it can be used by a compounding pharmacy to compound prescriptions specifically for the patient. that may have some differences. Now, there are some rules about compounding that I was extremely familiar with that had to do with the fact that you couldn't just basically take a copy of a 100 milligram progesterone capsule and make a 100 milligram progesterone capsule and compound it and call it compounded. It had to have some substantial difference.
Okay.
So if it was 150 milligram, that's enough different. Or if it had some ingredients taken out because the patient, these progesterone capsules happen to be made with peanut oil. A lot of people are allergic to peanuts. And so that's an ingredient that you can't have if you're allergic to peanuts. So that would be one reason why a patient could get 100 milligram, but without any peanut oil or peanut ingredients. And there are lots of other ways. Compounding pharmacies are basically required to make prescriptions that are a little bit different than the FDA-approved version. And many times those differences are a benefit for the patient, like not having an ingredient that causes allergy or having a real specific dose. Maybe that patient needs 175 milligrams, which you just can't do with a commercially available product. And so that's kind of the basics. I know you're probably going to ask me a little bit about the good and bad of compounding pharmacy, but let's talk a little bit more about it.
Yeah, no, that was helpful. Thank you. I'm one of those people who, well, not that I have an intolerance to progesterone, but I had started on Prometrium myself at 100 milligrams, and I've been on it now for, I don't know, a couple of years. And I kind of was playing with 100 to 200 milligrams. I'm like, oh, I don't feel great with 200, but I feel like I could be better. So I just switched to a compounded progesterone, and I'm at 150 right now. So I'm playing with that dosage. And yeah, I mean, I can see the benefit of having that option. I think it's wonderful that we have both options. So when it comes to compounding pharmacies, a lot of providers out there, some big name hormone specialists, they will poo-poo compounded hormones, as you know, saying that they're not regulated. So can you talk a little bit more about that? You mentioned earlier how that 1 week where the FDA came in and was looking at your pharmacy. So they are regulated, but for some reason, this is not public information, or people don't want to like admit it. So can you talk a little bit a bit more about how they are regulated and how sometimes it's even more regulated than the commercial pharmacies, it seems.
Right. Well, I'll tell you, I love this question, Claudia. And the reason is, think about your doctor. If you go to a physician or a nurse practitioner, how is your doctor regulated? Your doctor is regulated by the State Board of Medicine. Or if it's a nurse practitioner, that nurse practitioner is regulated by the State Board of Nursing, or there may be a combination. Depends on the state. But in every case, healthcare provider is regulated by the state. Now, your doctor is not under the jurisdiction of the FDA. The FDA, their jurisdiction is about drug manufacturing. And they approve drugs for certain uses in certain disease states and that kind of thing. And sure, they can say something about what doctors do, but ultimately the doctor does not answer to the FDA. The doctor answers to the State Board of Pharmacy, or the State Board of Medicine, I should say. And the same thing applies to compounding pharmacy. Compounding pharmacy is not directly regulated for the most part by the FDA. It is directly regulated by the state in which it practices. Now, the pharmacy that I used to work for was licensed in 50 different states. It was a total nightmare to keep track of all those 50 different states as far as the regulations were concerned. Fortunately, I was not the one who was responsible for that entirely. That was a big job. But it's something that pharmacies do quite regularly. In general, the rules are pretty similar to each other. And, there's one state will require one thing and another state will require something else. But 85% of the rules are essentially the same. Also, compounding pharmacy is generally governed by what are called United States Pharmacopoeia. That's basically a nonprofit, non-government organization that comes up with very detailed, they're called standards, things that pharmacies need to do in order to be a quality pharmacy. One of the things that I recommend in terms of compounding pharmacy is if you can find a compounding pharmacy that has an accreditation.
Mhm.
And there are certain accreditations that I've been a part of. I've had those inspections. I mentioned an FDA inspection, but I've also had an inspection from an accreditation body that comes in and they look at absolutely everything about your pharmacy, all the way from how clean is your bathroom to what do you have people sign, and what documents are people required to look at. Where do your chemicals come from that you're putting into the compounded progesterone or the compounded estradiol? How thoroughly have your pharmacists and your technicians and your clerical staff and your cleaning staff been trained? How clean do you keep your compounding area? How well do you maintain your equipment? There's a thousand, not even it's more like 10,000 questions that they ask about a compounding
Wow.
pharmacy. And if a pharmacy is willing to go through that kind of rigorous kind of third-party accountability, it's a pretty good bet that what you're going to receive from them is a high-quality compounded prescription.
Mhm.
Anymore, it used to be, I worked for a mom and pop compounding pharmacy more than once, and sometimes they get a little sloppy. But anymore, those are kind of going the way of the dinosaur. There aren't very many of those left. And more compounding pharmacies are very high quality, very high. They're a little stressful as far as I was concerned. That's why I got out of it, because of the
Right.
regulations. And
Yeah.
so the idea that compounding pharmacy is not regulated is just a complete myth.
Yeah.
They are regulated in a totally different way than
Mhm.
drug manufacturing companies are regulated. There's a lot of parallels in those regulations. But from my perspective, you can trust a compounding pharmacy, especially if you get one that has an accreditation and really has a third party looking very, very closely at everything they do. And I can tell you that is an extreme amount of, I mean, it requires pharmacists like I was to be really on their toes. And,
Mhm.
and I think it's a really good thing to have a pharmacy that you can trust and have
Yeah.
a pharmacy that makes a really high quality compounded prescription.
Yeah.
Compounded preparation is the word we use. We don't call it a product, we call it a preparation.
Preparation. Okay. Yeah, I agree. I'm starting to form a relationship with the pharmacist at the compounding pharmacy that I've been using for a couple of different preparations, not prescriptions.
Right.
And I have found them to be very helpful and of course, I have millions of questions all the time. And they've been just really forthcoming. And, yes, it is a stressful environment because everything that you said, but I have so far been very pleased with the support that I've been given because I mean, you're taking something in, like you should be able to ask questions. And unfortunately, a lot of women are going to their doctors, and even if they're prescribing hormones, they aren't usually hormone savvy. So sometimes I say to my clients, not sometimes, often I'll say, ask the pharmacist. They often know more than the doctor. So
Well, and that's
we
been
could
my
talk a little bit about
experience.
that actually.
As a pharmacist, I get a ton of questions. I have a YouTube channel.
Hmm.
I'm just making my 100th video
All
today
right.
after I get off the call.
Great.
And I've had thousands of people ask thousands of questions right on my channel, and I get probably 20 emails a day of women, especially women in menopause and perimenopause, asking tons of questions. And I love helping people answer those questions as much as I can.
Yeah.
At some point, I get more than I can handle. And I think that also can be a problem at the pharmacy counter. I have experience with that, where you just have this deluge of people asking questions. And that's where my material can come in and help
Mhm.
kind of take some of the burden off and help where people can get those questions answered on their own time and not at the stressful moment of picking up a prescription. There's four people standing in line behind you, that kind of thing.
Right. Yeah. And that's awesome. Like you're just going back to your course. It's the way that it's organized. It's like they're very common, like frequently asked questions that women ask. And the videos are like 2, 3, 4 minutes. Like they're all really short. And I love that because sometimes you do just have like a specific question and you don't want to have to watch like an hour long presentation, especially me as somebody who is educating and guiding clients. But of course, the average woman is busy and they're already stressed out and overwhelmed dealing with the perimenopausal to menopausal transition. So anything that's, quick and just gives them the information that they need is so incredibly helpful. So let's get into HRT in general, hormone replacement therapy. We've talked quite a bit about, the difference between the commercial versus compounded. Like, I'm sold on it. I don't need any convincing. I think it's great that we have both options. I hope that this opens women's eyes, and hopefully other providers who listen to this to not poo-poo compounding pharmacies, because they are a really great option for women. Actually, I do have one question and then we can get into HRT.
Okay.
A question that I often hear from women is, will my insurance cover compounded prescriptions? So can you give any insight into that?
Well, the answer is mostly no. There are some compounding pharmacies that still bill insurance companies. One that I used to work for, that's a few blocks from my house, they still bill insurance, but it's becoming a lot less common. I've kind of dealt with this a little bit on my YouTube channel because I have this question a ton
Hmm.
that has to do with compounded prescriptions for hormone replacement therapy, but also with physicians and nurse practitioners, that the relationship between those things and insurance is something that's often disconnected. And there's a reason for that, because health insurance and the medical establishment that's really run by health insurance, they don't care about your hormone optimization. They
Hmm.
don't really care how good you feel and how low your symptoms are as far as hormones are concerned. They don't really believe that optimal hormones are going to make a real difference. And so they're not that willing to pay for either a provider or for prescriptions that are going to help optimize your hormones. That's unfortunate. And for a lot of people, it makes hormone replacement therapy and hormone optimization kind of out of reach for them.
Hmm.
But that's the way it is. And I
Yeah.
wish I could tell a different story,
Yeah.
but I can't. And as a person who has relationships with literally hundreds of doctors and nurse practitioners and PAs all over the US and Canada, Canada's a little different because they have the national health, but it's actually the same in Canada and the UK because most of the doctors who deal with hormones are what are called private pay.
Hmm.
So they're not on the national health for hormones, even in those countries that have national health.
Yep.
It's just the way it is because the system is not really designed to encourage people to get their hormones optimized. Unfortunately, that's the way it is. And the same thing goes with prescriptions. You may be able to get some of them covered, but for the most part, a lot of pharmacies are just pulling back and they're not willing to deal with all that mess
Yeah.
with insurance. And what's going to happen is the insurance company is going to pay them pennies on the dollar, and it's not going to be financially worthwhile for that pharmacy. Obviously, as
Hmm.
a compounding pharmacy, they can charge whatever they want, and some are higher and some are lower. That's a whole nother story that I don't necessarily get into.
Yeah.
But it is a difficulty. Not everybody can afford to have their hormones optimized, but I'm sorry, that's just the way it is. Well,
No, hey, that's the truth, right? And I will never pretend to know anybody's financial situation, but as a health coach, I cannot accept insurance. And what I will continue to tell women is, what is the most important thing? Your health. We will find money to pay for anything and everything, right? I mean, there's so many things that we pay for that we don't necessarily need. So when it comes to your health, is it that you really can't afford it? Or is this just such a paradigm shift that you have to make because you're so used to being able to go to your doctor and pay a $15 or $20 copay and go to your local pharmacy and pay $10 for a prescription? But what I always say to women is, well, why are you reaching out to me? Because clearly that's not working for you, right?
right.
You're here because you're feeling lousy. You're not getting the support you need. So this requires a mindset shift. And no, nobody wants to pay all this extra money. I don't love to pay out of pocket for things. I wish everything was covered, but that's just not the reality. What's important to me is my health. So I would rather skimp on other areas of my life and have a tighter budget so that I could allocate funds to my health, because in my opinion, it's the most important thing. All right,
Absolutely.
I'll get off my
Yeah. I
soapbox
also
with
get
that.
I also get a lot of people who say two things. One is I talk to my primary care provider, who's the in between the lines that says they're on my insurance. I
Mhm.
talked to my primary care provider, and they didn't know anything about hormones, or they told me I couldn't take them, or they basically dismissed all of my concerns. And now you're telling me I need to go to a hormone specialist, but they're going to cost money. It's like, well, you've got a primary care provider who's on the insurance that doesn't know anything about hormones and basically denies them to you.
Mhm.
Or you can actually pay for somebody who does know about hormones. It's going to cost you, but you're actually going to get some relief.
Right.
So you kind of make your choice in some
Mhm.
ways. Obviously, like you say, it's a difficult decision. I know for my wife and myself, we pay a very significant portion of our income
Mhm.
on healthcare that includes seeing a hormone optimization specialist and getting prescriptions that are from a compounding pharmacy. It's not a small proportion of our income. It's
Yeah.
actually, I think, the second biggest expense that we have. So something that we put our money where our mouth is.
Yeah. Yeah, me too. I mean, I have an integrative doctor who happens to be quite hormone savvy, and I was very lucky to find her. And I have my knowledge, so we have conversations, and then we come up with a plan. And so far, it's been good. But I pay that out of pocket, and it's just something that I budget for every year. I know that I'm going to see her however many times a year. I know that I'm going to pay X amount for my hormones, and I feel so much better because of
Sure.
it. All right, so let's get into hormone replacement therapy in terms of what do you see being some of the common myths or misconceptions about hormone replacement therapy?
Probably the biggest one is that there's just this general idea that hormone replacement causes breast cancer or increases the risk for breast cancer.
Hmm.
And that, as you probably know, Claudia, comes directly from something called the Women's Health Initiative. It has been 23 years since the Women's Health Initiative was abruptly stopped. And this was literally one of the largest, if not the largest, clinical trials that has ever been conducted in the history of medicine. And there were something like 16 or 17,000 women who were either given placebo or they were given hormone replacement. The particular type of hormone replacement is something I'll mention later, but basically the report that came from that study was essentially overblown in the media. And the big headline was breast cancer risk increased by 26% using hormone replacement therapy. And people are like, all these women were literally throwing their hormones down the toilet and screaming at their doctor's office saying, why are you trying to kill me? Why are you doing this? But if you read, all you have to do is look at the report from the Women's Health Initiative, the actual study. The report does say that there is like a 26% increase. Theoretically, it's called a relative risk. And I go into a lot of detail in one of my videos on YouTube about what is said and not said in the Women's Health Initiative. But essentially, the increase in breast cancer was considered not statistically significant.
Mhm.
So there was a very slight increase, and technically it looked like 26%. If you zoom back, it was like out of 10,000 patients, 30 of them would have gotten breast cancer without hormones. 38 out of 10,000 got breast cancer with hormones. And
Mhm.
so it was actually 0.8% the what's called the I forget the words. There's the relative risk, and then the absolute risk is
Mhm.
0.8% increase. So it was a really small increase, and the statistical significance is something that basically says mathematically it wasn't all that big of a deal. It could have been just by chance that a few more people had breast cancer. I follow Dr. Peter Attia. He's one of my influencers, and he has a lot of stuff about hormones and
Mhm.
longevity and that kind of thing. And one of the things that he mentions is the number of extra women who died from breast cancer in the Women's Health Initiative because they took hormones was zero.
Mhm.
No women died who took hormones more than women who didn't take hormones. The the level of mortality was basically the same. And
Mhm.
that's what happened over the last 20 years is we've seen this supposedly massive increase in the number of breast cancer cases. It's just not there.
Yeah.
And there are a lot of other studies that show if you use a different type of hormone replacement therapy, the risk is actually even lower than that.
Hmm.
And so there's a whole lot of detail in the Women's Health Initiative that most doctors have not even read, because if they had read it, they would say, "Oh, hey, this doesn't really say what I read in the newspaper or read on the website headline about hormones cause breast cancer." There are
Hmm.
other kind of pieces of the Women's Health Initiative, like the idea that hormones increase your risk for heart attack and stroke and blood clots and all these other things, that they're basically just overblown. And the research is pretty clear that ultimately hormone replacement therapy either is neutral. A study just came out in March or April that talked about women over 65
Yes.
taking hormone replacement therapy. And the vast majority of all of the different risks included in the study, and there were quite a number of different risks, heart risk and blood clot risk and breast cancer risk. The vast majority were either neutral, didn't make any difference up or down, or slightly decreased. There were a
Mhm.
few that went up a little bit, but most of them were, and this was, I can't remember how many it was. It's like 29 different risks, and 27 of them were neutral or reduced.
Mhm.
So there's a lot of evidence now that goes against the idea, at least the headline idea, that hormones cause breast cancer, which, as I mentioned, was not in the study. It just was
Right.
kind of extrapolated hype from the
Mhm.
study. There's a whole book that I've recommended it to a lot of people. It's called Estrogen Matters
Yep.
by Dr.
I
Avram Blooming.
yes,
And
I have it
I don't
right
agree with
here, and I recommend it often whenever anyone challenges me. I'm like, just get this book,
right, right.
or give it to your doctor.
I don't agree with everything that Dr.
Yeah,
Blooming says. He does not like compounded
I
prescriptions.
know.
That's fine. He totally sticks with Premarin, which I probably wouldn't offer to anybody. One thing to point out that your listeners may or may not know is that the hormones that were used in the Women's Health Initiative included Premarin, which
Right.
stands for pregnant mare's urine.
Hmm.
So I took a Premarin tablet one time and cut it in half and smelled it. It smells like horse pee. It's disgusting. And I threw it away and washed my hands really quick. Because it is literally made from horse pee.
Wow.
Um, it's probably a really dirty, messy, contaminated drug that's been around for, it literally has been around for 75 years. And so we have so much better hormone replacement now than we did 25 years ago.
Hmm.
Uh,
Yeah.
so that's my soapbox about the Women's Health Initiative and hormone replacement therapy.
And well, some of the hormones that were used were not bioidentical hormones,
Right.
which is a
So
huge, factor. Just a
I
minor
have
detail.
I have a whole video on my YouTube channel where I talk about bioidentical hormones. Now, the term bioidentical has taken some hits in the
Yes.
past, but essentially it means a hormone that is chemically identical to the hormones that are made in human ovaries
Mhm.
or in human testicles, whatever. They're hormones that are chemically indistinguishable. They're exactly the same. Now, there are hormones that are chemically altered. They're changed just a tiny little bit. There's one called medroxyprogesterone.
Mhm.
It sounds like progesterone, but it has what's called a hydroxy group or a medroxy group attached to it. And if you look at the chemical structure, it's almost identical. Not quite, though. There's a little tiny change. And that little tiny change means that medroxyprogesterone has a higher tendency to cause blood clots.
Mhm.
It increases the risk for breast cancer, a small amount, but it does increase the risk for breast cancer. It means that medroxyprogesterone has basically zero effect on sleep, where progesterone has a massive effect on sleep, and it's very, very effective at helping women in menopause and perimenopause sleep.
Mhm.
It has zero effect on mood. Progesterone has a major effect on anxiety and depression in a lot of women,
Right.
especially the depression that comes after menopause. So that tiny little tweak, where if you looked at the structure, it's barely noticeable, it makes a huge difference in the way that that hormone actually works. And that's why it's always important to recognize, is this in a study, let's say, are they talking about progesterone or are they talking about a progestin? which
Hmm.
is like progesterone, but it's been chemically modified, like medroxyprogesterone, for example. And there
And
are other examples of that kind of thing too.
yeah, and sometimes I feel like those terms are used interchangeably, which can be very confusing to women. And you're like, wait, what are
Very
you talking about? Are you talking about progesterone or progestin?
right.
Yeah.
And you can see where the confusion comes in because they sound so similar, but they
Mhm.
are very often used. Even Peter Attia, who's a health influencer, Dr. Peter Attia,
Mhm.
he uses those terms interchangeably and drives me nuts.
Me too.
He talks about a progesterone IUD called
Yeah.
Mirena.
Yes.
Well, Mirena does not contain progesterone. It
No.
contains norethistrone, I believe it is, but it's not progesterone. It is a
Right.
similar drug, but not the same as the hormone progesterone. It's
Yes.
just a lot of people confuse those. And so we have to be very precise in our language.
Yeah, and it's already a very confusing topic. It's so nuanced. I had this conversation with a client, actually a couple clients recently, because, well, one in particular had for years a Mirena IUD, and she's been dealing with sleep issues and anxiety. And I said, well, do you need that for birth control? Because if your doctor's just telling you to use that for your symptoms, you're not going to find much relief because it's not progesterone. So she recently switched to progesterone. So I have to check in with her to see how she's doing. But they don't know what they don't know, and then they don't know what questions to ask their doctors. So that's kind of what I do. I educate a bit, but yeah. Anyway, let's talk a little bit more about obviously we're talking about hormones and hormone replacement therapy. Obviously, we're both big fans of hormone replacement therapy. So why? Why is hormone replacement therapy so important when it comes to reducing our risk of chronic diseases? Can you get into that a little bit and what specific chronic diseases?
Yeah, I use the term hormone replacement therapy quite frequently, but the term I like even more than that is called hormone optimization. I
Station.
like to
Hmm.
say what we're shooting for is that you get your hormones so they're not too high and they're not too low, but they're just right.
Hmm.
And just right hormones can do two things. Number one, they can either reduce or in many cases eliminate any symptoms that are caused by the loss of those hormones. And number two, they also can reduce your long-term health risks. And for women, as you go into menopause, here's one example. You go into menopause at around age 51 on average, if you haven't had a hysterectomy, in which case it might be much earlier.
Hmm.
But you go into menopause and your risk of heart disease is about half of what men's is. But by age 60, after you've been out of menopause or gone through menopause and you're postmenopausal, your risk for heart disease catches up with men in about 10 years. So heart disease is just one aspect of long-term risk that women who lose their estradiol and lose their hormones have increased risks of cardiovascular disease. So cardiovascular disease is the number one killer of men and women after age 50. It's actually the number one killer of men and women of all ages.
Hmm.
Your risk of dying from heart disease is somewhere between 1 in 3 and 1 in 2. So it's huge. It's absolutely huge. Another risk that people just don't even think about is when you go into menopause, you lose your estradiol.
Hmm.
The evidence is very clear that within 5 or 10 years, you could lose up to 20% of your bone density, your bone strength,
Yep.
and have a broken bone, primarily a broken wrist because you've fallen and you hit your hand or your arm. But even worse is a broken hip.
Mm.
And a broken hip, uh, 30% of people who fall and break their hip die within a year. You think a broken bone, well, you can survive from that, but a lot of people don't make it.
Right.
And this is a huge problem in women. And women end up, because they have a broken hip, they end up in a rehab facility and sometimes in a nursing home, and sometimes they lose their independence.
Hmm.
I tell the story of my mother-in-law who lived to be 101, but she had bad osteoporosis. Her bones were crumbling, especially in her spine. She couldn't walk for 10 years. And so she's in a nursing home and she's wheeling around in a wheelchair. And, it was very sad to see her lose all of her independence. And
Yeah.
this is a serious, serious issue that women need to be aware of. What I like to say is women who have, let's say, hot flashes, or they have some severe menopause symptoms, those women are kind of lucky
Mhm.
because they're motivated to do something about those hormones, the loss of their hormones that is causing things like hot flashes and other symptoms. If you don't have any symptoms, then what's going to happen is, well, I don't care. I don't need any hormones. And then
Exactly.
you're still going to get the loss of bone. And over time, you're going to get osteoporosis. And it is a very, very serious problem. Those are
Mhm.
just two of many problems. The four that I like to mention, though, are heart disease, number one, osteoporosis, number two, type 2 diabetes and insulin resistance, number three, and
Mhm.
then Alzheimer's. When you get
Mhm.
to be 80, 90 years old, the chances are higher if you don't have optimal estradiol and progesterone along the way that you may develop Alzheimer's disease. And there are a lot of other factors. Uh, Diabetes is one of them, and the way your diet and exercise and toxins and all kinds of factors. I actually have a whole course that I call 5-minute action steps to a healthy brain that's about protecting yourself from
Mhm.
Alzheimer's and reducing your Alzheimer's risk. And one of the key pillars is optimal hormones that aren't too high and they're not too low, but they're just right. Because that's an important part of protecting your brain. Everything runs on hormones. Everything in your body runs on hormones. And
Mhm.
so, in order to have your body function properly, you've got to have those optimal hormone levels. And frankly, all we have to do is look at our own systems. When we don't have enough hormones, everything goes to hell in a handbasket. And when we do have those, we feel great. In
Yeah.
general, it's a little bit of an art and a science sometimes to
Mhm.
get things adjusted, but in general, we'll feel a lot better.
Yeah. Yeah. It's something that it makes me really sad to see. I'm dealing with that with my mom right now. She's 72 and she knows what I do for a living. And she's like, Nobody ever talked to me about hormones. When I went through perimenopause, like I had horrible anxiety. I had hot flashes. I had this and nobody ever said anything. And they gave her a Xanax and that was that.
Right.
And I think she had like an ablation at one point and never really revisited it. And now, we just got her DEXA scan back and it says she's got osteoporosis. And I said, Mom, we need to do some work here. And at 72, doctors are hesitant, of course, to give hormones. And I come in there with my studies and I'm like advocating for her. And, hopefully we can do some things for her. But, obviously food and lifestyle is huge. I feel like you're never too old to change your diet, your lifestyle. But yeah, the earlier the better with hormones. Would you agree?
I would agree. I would also say, and Avram Blooming in his book Estrogen Matters hits on this quite a bit. He has a whole chapter about bone density and the difference that hormone replacement can make in strengthening your bones. I will say that diet and exercise are important, but if women have this notion, I'll just take calcium and vitamin D and my bones will be fine, that is not correct.
Mm-mm.
Calcium and vitamin D are fine. They're not hurtful for the most part, but they do very, very little to strengthen your bones.
Mhm.
And even if you take, they're called bisphosphonates. There's one called Fosamax, an older one, and then there's some newer ones, and then there's some newer drugs. They have some major disadvantages, these drugs that are given for osteoporosis. The most effective treatment and the most effective prevention for osteoporosis is having optimal, just right levels of estradiol. And so, the idea that we can exercise and we can take calcium and vitamin D and we can have a good diet, those are great, but without optimal hormones, they're going to fall short. And
Yeah.
a lot of women email me that. I think I've probably gotten an email maybe yesterday that basically said, I eat a great diet and I eat lots of vitamin D and calcium and blah, blah, blah. And I exercise all the time, but I'm still getting osteoporosis.
Hmm.
And that's just the way it is. Those are
Hmm.
not enough to
No.
make enough of a difference.
No, and sometimes if you you don't optimize your hormones, you get to a place where you have aches and pains and you can't move. So then you can't even exercise. And that's kind of where my mom is right now, where she's like, I can't imagine lifting weights. I'm like, well, yeah, I should have probably done it a while ago. Coulda, woulda, shoulda. But anyway, yeah, I think it's so important to get your hormones optimized. Obviously, we've been talking about this. And progesterone as well, right? Doesn't progesterone also have an effect on your bones? Can you speak to that a little bit?
Progesterone does have an impact. I was just actually looking at some studies. The impact of progesterone on bone density is substantially lower than the impact of estradiol, but there is some. And I think the combination of estradiol and progesterone, which is the best practice, the best way to do it is to take both of them. Um, if you can't take estradiol for some reason, that's in my mind going to be a very rare situation. But if you can't, then progesterone will have some positive impact on increasing your bone density, but it's not nearly as much as estradiol. Even for men,
Mm-hmm.
the studies have shown that the main thing that helps men keep bone density is that they have testosterone that gets converted to estradiol.
Yes.
And estradiol is really the main driver. There are two different systems that happen. There's a bone building system and a bone breakdown system. And so your body has to balance those two out. If you have more building than breakdown, then you're going to build bone. If you have the opposite, you're going to lose bone. And so estradiol is really about building bone rather than breaking it down. And that is the key. If that hormone is missing, then there's not really anything that kind of balances that process out. And so you end up losing bone and not building it back up.
Mm-hmm.
There are one other factor that's important, actually, too. Exercise. I mentioned exercise and diet. So drilling down in that a little bit, having an adequate level of protein in your diet is huge because part
Mm-hmm.
of what it makes up bone is calcium, and another part is protein.
Mm-hmm.
So you have to have enough protein to build bone. Another thing, and you mentioned this a little bit, is weight-bearing exercise is a huge benefit for your bones. The more you can lift heavy things, and that might be heavy for you. Maybe it's 3 pounds, maybe it's 5 pounds, maybe it's 40 pounds. But whatever's heavy for you, lifting those things is going to help strengthen your bones. And those are super important. Again, though, without any estradiol, they're going to fall short and you're not going to get enough. But we need the combination of all of those things. This is a topic that I'm very interested in. I actually have a video on my YouTube channel that's about sarcopenia and osteoporosis.
Mm-hmm.
Sarcopenia is muscle loss, and osteoporosis is bone loss, which are absolutely massive problems in older people. You see the little old lady or the little old guy walking with a walker in the
Mm-hmm.
grocery store can barely make it down the aisle, and that person doesn't have enough strength in their
Yeah.
muscles and bones, and they may have fallen and broken their hip, which is why they're on a walker. And this I'm 100% convinced that the problem in old age is not the old part, it's the weak part.
Mm-hmm.
We don't just get old, we get weak, and we sit around and watch TV and we don't do any exercise, and we avoid really eating enough protein and strengthening our bones and our muscles. And that's the thing that's going to get us. And there's a lot more evidence that's coming out in the last few years that shows these are huge problems for people. And they run into other health issues like diabetes and obesity and other things because they don't get any exercise and they don't eat right.
Right.
And we need to, as younger people, I'm in my 60s, we need to start looking at that and start preparing by, building that muscle and building that bone and making sure that we keep things as strong as possible for the long haul.
Mm-hmm. Yes, that's why I get on my soapbox. And, I'm in my 40s and I'm over here like, ladies, start now. You're already starting to hear those whispers. You're starting to get the symptoms. Your hormones are changing. I mean, I tell women it starts in your 30s when we start to lose progesterone. And then in your 40s, your estrogen fluctuates, but make no mistake, it's going to start to decline. So why not get on top of it now? So, okay, let's shift focus a little bit to the different types of hormone therapies. So there's a lot of conflicting, I mean, there's conflicting information about everything we've talked about. But when it comes to oral versus topical, progesterone and estrogen, and then even testosterone for women specifically, the fact that there isn't an FDA-approved testosterone. Can you kind of speak to a little bit of this in terms of, what you see maybe work better for others, like just your opinion on them?
Yeah, so I'm kind of in the school of thought that does not say absolutes.
Mm-hmm.
So, for example, there are a lot of doctors and nurse practitioners who would never give oral estradiol.
Correct.
I don't necessarily believe that's the best way to go about it.
Mhm.
Oral estradiol is, first of all, it's very convenient to take a capsule, put it in your mouth, and swallow it. Piece of cake. Putting on a cream or a patch may have maybe a little bit more difficult. Sometimes the patches come off. They may or may not last 3 or 4 days, however long they're supposed to last. The dosing can be a little bit of a difficulty where if you need a dose that's kind of in between, sometimes that's a problem. Using a transdermal gel can be, messy sometimes. Now, I understand the primary reason why doctors and nurse practitioners will say don't ever take oral estradiol is because they believe that oral estradiol increases the risk for blood clots.
Mm-hmm.
I have a whole video about this on my YouTube channel. The information about increased blood clot risk is really mostly about Premarin. Premarin, when given in an oral form, does have a tendency to increase blood clot risk. And estradiol, however, bioidentical estradiol may increase it in some situations, but it's much lower of an increased blood clot risk for bioidentical estradiol.
Mm-hmm.
In my informed professional opinion, there are certain people who maybe have had what's called a deep venous thrombosis, which is a blood clot in your legs that can possibly go up and become a pulmonary embolism in your lungs. Basically, you're dead.
Yeah.
That's a serious problem. If you've had I actually had an ultrasound 2 weeks ago because my doctor, a doctor I went to, was concerned that I might have a deep venous thrombosis. Now, it turned out that I don't. It turned out that I don't have a DVT or a blood clot, but it was a concern for me.
Mm-hmm.
If someone has that, then it might be a situation where maybe they should avoid an oral form of estrogen. But for the most part, and there are a few other examples, for the most part, though, most people are not going to have that risk problem. So that's an example of oral versus transdermal, where really it depends on the individual. What I don't like to do is make a blanket statement and say,
Mm-hmm.
like, for example, I talked earlier about women over 65. If you're over 65, you can't take hormones. Well, that's a blanket statement. There are women over 65 whose health and their cardiovascular health and their overall health looks pretty good, and maybe they don't necessarily have a lot of these risk factors, and maybe they're unlikely to have some heart issues, and so they should be perfectly fine taking some estradiol and progesterone, even though they're 10 or more years past menopause. I don't like to make a blanket statement and say never take oral estradiol or never give hormones after age 65. It's all about having a hormone optimization specialist, somebody who really understands the real risks and what really goes on with an individual at the individual level, not like a population level. And that's the problem that I see with a lot of like mainstream medical resources, or maybe your primary care provider or your OBGYN. Many of the decisions that those providers will make are based on a population. They're based on a blanket statement for everybody that's not necessarily applicable to you personally. And that's what you really want, is someone who can really look at you personally. And sometimes it's a health coach that helps you see your personal situation. And sometimes it's a more knowledgeable, more trained healthcare practitioner that can kind of dig down and look at your specific risks rather
Mm-hmm.
than making these blanket statements.
Yeah, I agree. That's something that kind of drives me bananas in just the health space. There's a lot of black and white thinking, and I've been doing this for 12 years now, maybe a little longer. And I just have, for years, I've come to that place where I'm just like, everybody is different. Every woman is unique, and what works for one person may not work for somebody else. And we have to take into account somebody's lifestyle, their budget, their health history, their needs. I mean,
Yeah.
I don't like the black and white thinking either. So I'm glad that you feel the same. In terms of progesterone, I feel like this is another one that like if somebody uses a progesterone cream versus oral micronized progesterone, there's people that say, oh, the cream is just placebo, it doesn't do anything. I have not seen that. I mean, I personally don't use progesterone cream. Well, I've played with it, of course, I've dabbled in it, but I use oral micronized progesterone. It helps with my sleep. When I had anxiety, when I first started my perimenopausal symptoms, it really helped. But we have clients who like they'll buy an over-the-counter progesterone cream and they're like, oh my gosh, I noticed such a difference and whatever. So can you speak to that a little bit?
Yeah, I just said that I don't like to make these blanket statements, but
Yeah.
I'm going to make one anyway.
Yeah.
In general, I like progesterone in an oral capsule better, and there are some
Hmm.
very specific reasons for that. Now, I also draw a line. Let's draw a line at menopause.
Hmm.
As you and I both know, menopause is basically one day. It is
Hmm.
the day that is 12 months or 365 days after your last menstrual period. That day is considered menopause. Everything after that is considered postmenopausal. So up until that point, maybe for 4 to 6 years, you're perimenopausal, maybe even 10 years. Perimenopause is a different story than postmenopause.
Hmm.
So perimenopause, there are a lot of symptoms, and uh, perimenopause, frankly, is much more complicated
Oh
than
yeah.
menopause. Menopause, basically, you don't have any hormones and you need to have them replaced.
Yep.
That's the answer. But perimenopause is, well, you've got hormones, but they're like this and 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 all over the place.
Hmm.
And so one approach that a lot of providers have is to use maybe progesterone, and it could be in a capsule or a cream form, to kind of help kind of manage some of those symptoms of the ups and downs. In general, doctors won't prescribe estradiol as often for women in perimenopause because there's a very strong likelihood they could get too high on it because they're still making some.
Hmm.
Um, but they can use progesterone in whatever form works for them. But after menopause, there's a lot of evidence that the type of progesterone that is most effective is oral micronized progesterone.
Hmm.
And the reason for that is this. There are two reasons. One is estradiol. If you're taking estradiol after menopause, it's going to help with hot flashes and other symptoms, weight gain and irritability and mood swings. Estradiol naturally causes a buildup of the lining of the uterus. It's called the endometrium. And that gets thicker and thicker and thicker. That's the way it's supposed to work. That's the way it works before you go into menopause. So before you go into menopause, estradiol works that way. After you go into menopause, if you're taking estradiol, you need to keep that overgrowth of the endometrium in check. And progesterone is what does that. Unfortunately, the progesterone cream hasn't shown to be all that effective at
Hmm.
decreasing the overgrowth of the endometrium. I actually have talked to several providers who've told me kind of horror stories where someone came to them, they had been on a progesterone cream, and the doctor or nurse practitioner took what's called a transvaginal ultrasound to look at how thick is their endometrial lining, and it's like getting a little out of control.
Hmm.
And I've heard multiple stories where this patient starts with this new doctor and they check their endometrium. It's really thick. It's not being taken care of by this cream. And
Hmm.
this has happened over and over and over again. And they're like, "Oh, we got to do something about this."
Yeah.
And the capsules just don't have that problem. There's a lot of evidence that the capsules work. The
Hmm.
second reason progesterone in a capsule form is better, in my opinion, is that progesterone in a capsule form goes into your mouth, goes into your stomach, and then it goes straight to your liver. And people are always thinking, oh, I don't want that liver first pass effect, which is where your liver metabolizes that hormone.
Hmm.
But in the case of progesterone, that liver first pass effect actually turns progesterone into a metabolite called allopregnanolone. And allopregnanolone is the main reason why progesterone helps with sleep.
Mm-hmm.
It's the main reason why progesterone helps with anxiety and with depression in most people. And so if you don't take it orally and you take it on the skin, you may get blood levels and you may get, some incorporated into your system, but not nearly as much turns into this allopregnanolone. And that has a huge impact on the symptoms. I don't know the numbers, but I would guesstimate something like 10 or 20% of the activity of a oral micronized progesterone capsule is what you would get with a progesterone cream, substantially lower. It might still help some, but it's going to be a lot lower in effectiveness, especially for things like sleep. And I've heard this over and over again from physicians, from patients. It's just huge. So, two things. Number one, it doesn't work for endometrial hyperplasia or build up the lining of the uterus. And number two, it doesn't work very well for sleep. But other than that, the progesterone creams are okay. They're not necessarily harmful unless you're taking estradiol and it's overgrowing the uterus, which is a problem.
Yeah, that makes sense. And it's not just about symptom improvement. That's what I try to explain to clients too. Like, obviously, we want to feel better. We want to eliminate our symptoms, but we also have to think about other ramifications. So making sure that you're using the right form and obviously getting to the right dose and the right level. So another thing that's very controversial is testing hormones and all of that. And we don't have to get into the nitty-gritty, but how do you know if somebody is at an optimal level besides just monitoring their symptoms?
Well, monitoring symptoms and talking to the patient. And I have always been from the school of thought that says you treat the patient and not the numbers. At the same time, you also have to look at the numbers to make sure that they're within a reasonable range or within what I would call an optimal range. And there's this idea of normal is not necessarily optimal. The normal estradiol level for a woman past menopause is really close to zero because every woman past menopause has no estradiol at all. That's normal, but it's not optimal. And so I'm a firm believer in general in serum or blood testing. I think that is the type of testing that has the strongest amount of research, like 10 times as much research goes into serum or blood testing as any other form. Now, I'm not necessarily saying that saliva testing or urine testing or dried urine testing, none of those are necessarily wrong or bad. I would just say that the strongest amount of evidence is underneath saliva testing. And so that's generally what the doctors that I work with, the vast majority of them will go with a serum testing. They'll take a blood test. Now, there may be there may be special cases where there's a test called Dutch test, and there's another company that I've started working with recently called Vital Labs. They do like urine testing, and there are special circumstances where you kind of need to know how a woman might be metabolizing her hormones and what kind of changes her liver or her body is making with those hormones. That can be an interesting and helpful thing. But in general, it's not something you would go to first. It's something that would be, kind of reserved for kind of special cases when you're having issues or problems or if you have special risk kind of concerns. In general, blood testing is the best. Not necessarily exclusively, but in general, it's the best and has the best evidence.
And it's it's accessible. I say that to my clients. Like, if you're gonna choose a test, do you really need to spend the 300-400 whatever it is dollars on a Dutch test, or can you just go and get some blood work done and also monitor your symptoms? I mean, I'm always trying to think of my client's budget because this can get expensive. It's like, I'd rather you spend the money on the hormones and going to a hormone savvy provider, than necessarily spending money on all these tests out there that, when blood work is the gold standard. It's been around forever.
It's my experience and my wife's experience. A lot of times our labs are actually covered on their insurance. And I think my wife pays $26 for her labs every year. And it's like this long, 5-page sheet of a bunch of different hormones. But relatively reasonable. So, And
Mhm.
if it were a urine test or some other fancy saliva test, they would not be covered, and it would be hundreds of dollars.
Yeah.
So that's one aspect of this whole picture that generally is covered is if you get blood labs. I don't know how frequently, but our experience has been quite frequently it is covered by insurance.
Hmm. Yeah, that's what we have found too. All right. We covered a lot. We can keep going, of course, right? There's so many things we could dive into. Maybe we'll have you back another time and talk about some other topics, but um thank you so much. So, how could women find you and learn more about you?
Well, I have a couple of different ways that women can find me. One is through my website, simplehormones.com. It's kind of ironic. Hormones are not simple. They're actually quite
Nothing
complicated.
simple about them.
But what
But you
I'm trying to
simplify
do
it.
is simplify them in a way that anybody can understand, whether you have a medical or a science background or not. And so that's what my material on simple hormones is all about. I have basically two emphases. One is on patient information, and another is taking that patient information and helping doctors and nurse practitioners with it to teach their patients. And so there'll be a combination of resources available on my website. What I'm going to do though is I'm going to make my course available to your listeners, Claudia.
Mhm.
And so simplehormones.com/Claudia is going to be a special page. I haven't set it up yet, but I will set up that special page, simplehormones.com/Claudia, where I'm going to offer a little discount. And you can, if you want to take a look at my course, it's called the Menopause Solution.
Mhm.
That course is really all about making your HRT decision. That question, should I take hormone replacement therapy for my menopause, or you might look at it in perimenopause as well, or not? And this is, of course, as Claudia mentioned, it takes a couple of hours to go through. It's relatively small, everything's easy to understand, but it
Mhm.
answers a lot of the questions that women have. And it does so in a way that's kind of bite-sized.
Mhm.
The videos are five. I think the longest one might be 8 minutes or 10 minutes long. Most of them are 5 minutes or so, something like that. Um, but it also, gives you a little bit of access to me. You can make comments inside the course, and I try to answer those as quickly as I can. But my goal is really to help women make that decision about whether they want to take hormone replacement therapy and optimize their hormones or not. So that's one way that you can find me is simplehormones.com/Claudia. Another way is I have a YouTube channel. So if you go onto YouTube and just search for Simple Hormones, I have a ton of videos. I mentioned that I just am working on my 100th video. I just went over 1 million views on all my videos, which I'm pretty proud of.
That's
Um,
amazing.
so I have a bunch of videos. I probably emphasize 80% of my videos about menopause and perimenopause and a lot of the kind of topics that we've talked about today. Um, so those would be probably the two primary ways to look for my material. There's a wealth of information on my YouTube channel, and obviously, if you're going to cut right to the chase and get all the details all in one place, then my course would be the way to go.
Yeah, it's well worth it, ladies. Really. Like I said, I loved it. And there's even some really great PDF like downloads in there. And it's just such a great course to have. I just think it's so important, like I said earlier, about to educate ourselves. The earlier the better, so that we not only feel empowered, but so that we can better advocate for ourselves, because it is difficult to even find a hormone savvy provider. But what I find is there are some women, like some of our clients, who they have a doctor who is very open minded. And while I would absolutely prefer somebody go to somebody who is experienced and knowledgeable, I also think that things are changing where women are becoming so knowledgeable that sometimes we have to educate doctors. And even if it's just bringing them resources so that they can start to learn, and maybe they'll do Steve's course. That's how things start, right? We have to get out there and speak about it, talk about it. Don't be afraid to have these conversations with your friends, women in your circle, and obviously your trusted providers. But also know that the provider that you have had for many years that you love and trust may not be the person who's going to help you during this transition. So be open to working with somebody else. And like we said earlier, potentially having to pay out of pocket for that. So start saving your money and invest in yourself, because there's nothing more important.
I will add one little thing, Claudia, and that is you were talking about finding a hormone
Mm.
specialist. I actually have a network of
Mhm.
several hundred hormone optimization providers around the US, the UK, quite a few in Canada. And so if you go to my website, simplehormones.com/referral, there's
Mhm.
a form that you can fill out there depending on the type of doctor you're looking for, that kind of thing. And basically, I'll get in touch with you and kind of give you a list of doctors in your area. I can't guarantee that I know somebody in Poughkeepsie, New York, or Fargo, North Dakota, but I do have quite a few all around the country and around especially around North America.
Mhm.
So it doesn't cost you anything, and you might find somebody that really works for you. And some of them can do telemedicine, so if they're not super close, you can do a telemedicine visit with them, that kind of thing.
Yeah, that's incredible. Thank you so much. And we're going to include all of the links and everything he mentioned in the show notes. So make sure you check that out. Thank you again so much, Steve, for being here. It was such an honor to have you as my first podcast guest. This was an awesome conversation. Thank you so much.
Thank you for having me, and well, I look forward to coming again soon to be a guest. Maybe not the second guest, but later on.
Yeah, for sure. Thank you.
All right, thanks, Claudia.
The information provided is for educational and informational purposes only. I am not, nor do I act as a doctor or any other medical professional. I am not providing healthcare, medical services, or attempting to diagnose, treat, prevent, or cure any physical, mental, or emotional disease or condition. The information shared is not intended to be a substitute for the professional medical advice provided by your own medical or mental health provider.